So a pleasant morning to everyone in the United States and good evening to those in Uganda and other parts of the world. As mentioned, I'm Dr. Bernie Laya, and my talk today is on imaging of thoracic tuberculosis, particularly in children. So, to advance my slides, first off, I would like to state my objectives for this particular engagement. We will provide an overview of the demographics, the pathogenesis, and the diagnosis of tuberculosis in children. We'll discuss the imaging utilization and updates in the evaluation of childhood TB. And of course, we will describe the spectrum of radiologic findings that we see in the chest for childhood tuberculosis, present other entities that could mimic tuberculosis in children. And of course, we will do this, we will try to emphasize clinical radiologic correlation when we are interpreting these imaging studies. No? So just to give an update about tuberculosis in general, in 2023, there's about 10.8 million that fell ill with TB globally. This is slightly increased compared to 2021 and 2022. About 400,000 are new cases that have multiple or single drug resistant TB. So that's not good. As we all know, the determinants for falling ill to TB is undernutrition or malnutrition, alcohol use, smoking, HIV, and diabetes. About 1.25 million died from TB globally in 2023. So this is slightly diminished, but still not good. So as it stands, TB is the leading cause of death from a single infectious agent, and it remains one of the top 10 causes of death worldwide. In children, for 2023, the TB burden remains enormous. There were approximately 13 million cases. That's about 12% of the new cases of TB. They fall within the age of 15 and below. So this is a great burden in pediatric population. And of course, we know that diagnosis of TB in children could be challenging because most children have non-specific symptoms. Culture is not necessarily routinely done in children. And our routine tests, such as TB skin test, IGRA, has its weaknesses, a false positive and false negative. Even the gene expert, which is standard for adults, uh, is unable to detect culture positive TB in about 20 to 25%. So radiology still play a very important role. And of course, misdiagnosis could lead to severe health consequences, including delayed treatment, increased risk of transmission among children, and even to adults. No? So chest radiographs is the mainstay. It's the initial imaging test that we use for evaluation of childhood TB, for screening, diagnosis, all the way to follow up during treatment. Keep in mind that there's a wide spectrum of chest X-ray findings. It could be lymphadenopathy and consolidation, could be consolidation with cavitation. You could have destroyed lung or even disseminated miliary process. We will go through this one by one. But of course, to understand its radiologic manifestations, we have to understand pathophysiology on how we get tuberculosis. So if somebody coughs and the child is close by to a person who's infected with TB, the mycobacteria gets inhaled. Of course, it settles first in the lungs where it multiplies, the mycobacteria multiplies, and incite inflammatory changes in this area. And as the mycobacteria multiplies, it also travels to the lymph nodes, and the lymph nodes do enlarge, and the lymph node and the lung disease is the combination or what we call complex. So this is primary infection that is mostly seen in younger children. So the one that is inhaled and it settles in the lung is the gone focus. And of course, it travels via the lymphatics into the lymph nodes. So the lesion in the lung plus lymphadenopathy plus the associated lymphangitis is the gone complex or the primary complex. If the patient does have good immune system, this is quote unquote eradicated or kept at bay infection. So it's controlled, no? So, but does remain that there is the gone focus and there's lymphadenopathy. Sometimes the gone focus is very small on X-ray and we hardly see it, but we do see the significant lymph node enlargement. This is right hilar lymphadenopathy. So as I said, if the patient does have good immune system, this is kept in control and they go into latency. So latency is a preclinical state. So the patient has the infection. The patient, however, does not have clinical symptoms, but it could manifest on the quantiferon test, TB skin test, etc. But the X-ray may or may not have findings. No? So it's quote unquote eradicated, but it's still there. No? Unless the patient is treated, the infection remains within the patient. So the X-ray could be normal. Here, we don't see any lung changes. We don't see any significant lymphadenopathy, but the patient is harboring the TB infection. Sometimes we do see imprints of infection in the form of calcification in the lung, called calcified gone focus, or it could be calcification in the lymph nodes, such as what we see in this particular X-ray. So this suggests that the patient had infection. Of course, if the patient has not been treated before, this latent infection could be reignited later on. No? But on subset of population, once the patient gets the infection and the patient has failure immunity, maybe undernourished or other immunocompromised states, then the infection could lead to progressive TB disease. No? The symptoms depend on the age and the degree of dissemination. So where does it go? From infection, it could progress into significant pulmonary disease. It could progress into lymphadenopathy or a combination of both, or it could even go to other parts of the body via the hematogenous route. And this is what we call disseminated disease. No? So the primary progressive lung disease could be in the form of lung disease that cavitates. You could have a combination of cavitation in the lungs and multiple nodules that is arranged like tree and bud, we call them. That's a sign that it's an acute process. Or it could disseminate elsewhere, beyond the lungs. We'll see this miliary pattern. When we see this miliary pattern, we are sure that it could also be present in other parts of the body as well. So that's primary progressive lung disease. Again, this is the X-ray correlate. So it could be an opacification of the lobes of any lung. And we could even see cavitation. You see that air fluid level right there. The cavitation could be very, very obvious and significant and comprehensive like this one. The entire right lung is opaque and there is a cavitation in the lung. No? Just to give us a correlation, this is a CT scan of a chest on a patient with significant progressive lung disease on the left, and this looks necrotic. And when you're reading a lot of CT scans on tuberculosis, we see this kind of typically. No? Notice that there's also a necrotic lymph node in addition to the lung disease. And sometimes, in addition to the necrosis, we see cavitation also. So this suggests, on the proper context and the proper clinical scenario, that this patient has primary progressive tuberculosis. No? Primary progressive lung disease, as I mentioned, could also be in the form of miliary pattern, multiple nodules throughout both lungs. This is more obvious, of course, on CT scan where we see multiple dots, multiple small nodules uh, that is being described as millet seed in appearance. That's why it's called miliary tuberculosis. And on gross histopathology, we could actually appreciate those multiple nodules seen throughout the lungs. Miliary tuberculosis also suggests that the TB is already disseminated elsewhere in the body. So miliary pattern is a consequence of either primary tuberculosis or reactivation tuberculosis. It is seen more in children than in adults. And again, as I said, when you see miliary pattern, it's already disseminated, okay? Even though the patient is being treated, clearing of this pattern could be very slow. It could range from months to even years. So we have to really assess the patient not only on imaging, but also clinically and laboratory-wise. So TB involvement of other organs is common whenever you have miliary pattern. So in addition to progression of the disease in the lung, as we see it in the patient could also have massive progression of disease in the lymph nodes. So this is a combination of lung disease and lymph node disease. Okay, so progressive lymphadenopathy is common in primary tuberculosis. Again, the younger the child, the higher the incidence of progressive lymphadenopathy. Although it's usually unilateral, it could be bilateral. It's been written that it has a predilection on the right side, but this is not necessarily true all the time because we could see it also on the left side. It can compress the airway, which is a significant finding that we need to mention in the radiologic interpretation. No? So this is a patient with primary progressive lymphadenopathy. As we could see, the green lymph nodes right here are enlarged. It is causing obstruction of the airway, but not collapsing the airway altogether. So air could go in, but it cannot come out. So this is a air trapping. Sometimes the lymph nodes are too big that it compresses the airways, and in this case, it will collapse the lung. And this is what we call collapse atelectasis. Sometimes the lymph nodes are just there, and it does cause disruption of airflow. And in addition to the lung disease, it could cause significant inflammation of the airways. We call that bronchiectasis. They enlarge, the walls get thickened, and they get inflamed. So these are possible sequela on the airway of progressive lymphadenopathy. So this is an example on a CT scan on a patient with tuberculosis. As we could see, there are soft tissue densities right here with septations, and the pattern of enhancement looks like it's only peripheral enhancement. This is a matted lymphadenopathy from tuberculosis. Another example, large lymph nodes on the mediastinum. Notice what it does to the trachea. It does collapse and efface the trachea. So this is an important finding that needs to be mentioned in the interpretation of the imaging study. Okay, this is another patient with proven tuberculosis. And on the CT scan, we see the airway. That's the right bronchus. And here's the left bronchus. Notice how significantly narrowed it is compared to the right side, because we do have left lung disease plus calcified nodules effacing and eroding on the airway. On the axial view, you could see the lymph node effacing it on this side, but it's also eroding directly into the airway. And this is proven by the fiber optic bronchoscopy. This is actively caseating type of lymphadenopathy eroding on the trachea. This is a patient proven with tuberculosis. The X-ray does show that there's an opacity on the left lung. On CT scan, we see the opacity that looks necrotic in the lung. There's also matted lymph nodes in the mediastinum, and you see that it's being pancaked, no? So right here, we could see on this reconstruction view, there is significant circumferential narrowing of the left bronchus compared to the right side. And this is because of the lymphadenopathy. And this is the correlate bronchoscopy. So in addition to X-ray and CT scan, we could also use ultrasound for the evaluation of lymph nodes. But it is better if you already have the X-ray, and if you want to see if there's significant lymphadenopathy, ultrasound could be done. No? So ultrasound, you see a lot of rounded structures, but sometimes you don't know which is a vessel, which is a lymph node. So we can just apply color Doppler, and the one that does not have flow and it's rounded in structure is likely representative of lymphadenopathy in the proper context. Again, it is best interpreted in relation to the X-ray. So when you do an ultrasound, there are two different views that we put the probe on the suprasternal view, transverse and longitudinal, and parasternal view on the transverse and longitudinal. And if you know anatomy, and if you see additional structures there that look solid and on the proper context, that could possibly be lymphadenopathy. So what happens now that we know the TB does affect the lungs and the lymph node? So beyond the lungs and the lymph nodes, it also affects the pleural surface and also the covering of the heart, no? So the pericardium. So this is a patient with shortness of breath, okay? And there's obviously opacity in the lungs, particularly on the left side, but also on the right side. But the patient also has effusion. And a CT scan was done. What is interesting in this patient, this is the heart, and the covering of the heart is very thick. No? So this one is pericardial thickening or pericardial inflammation secondary to TB. And this is a diagnosis called constrictive pericarditis. So this covering does not allow the heart to pump efficiently. So there's also pleural effusion. So the patient kind of develops a heart congestion of some sort. So this is proven pericardial thickening secondary to tuberculosis. So in addition to the lung disease, as I said, so patient could have cavitation. But what is interesting in this patient, notice the significant kyphotic deformity. So even though we don't see it well on this particular imaging study, it's suggestive that there is Pott's disease. No? So an MRI was done on that patient, which I will show later. So Pott's disease begins as an infection in the anterior part of the vertebrae. It spreads into the end plates, and multiple discs and vertebral body are involved. So when they collapse, they cause what we call gibbous deformity, significant kyphostic deformity. So in addition to the bone abnormality, there usually is a soft tissue or an abscess formation right next to it. No? So this is the collapsed vertebral bodies, and this is the associated paravertebral soft tissue. It could be an abscess, it could be a soft tissue. But, you know, when we see this combination, we also have to look at how it affects the spinal cord. And here we see the spinal cord is being effaced and stretched by this bone and soft tissue abnormality. What happens now if the patient gets the infection and the patient is doing well, kind of quote unquote eradicated the infection, but later on in teenage years or in the adult life, the patient's immune status goes down. No? So Then there is reactivation of tuberculosis, and this is what we call post-primary tuberculosis, also referred to as adult type TB. No, this is what happens after long time of dormancy. So most common form of TB in adults and older children is post-primary tuberculosis. The imaging features usually is a consolidation involving the upper lobes due to decreased lymph flow. To show you, this is again the patient who had previous uh, tuberculosis, and the reactivation usually occurs in the upper lobes, and there is opacity, there's scarring, and even cystic or cavitary formation. No? So this is post-primary tuberculosis. Notice the opacity involving the apices, the apex, with cavity. When this patient gets treated, it doesn't go automatically all the way eradicated and or removed, no? Or there's still some stigmata. When you do CT scan, you will still see fibrotic areas and residual cystic changes. No, this is after treatment. And also, interestingly, on this patient, there's also abnormality on the right side, although we don't see it on the X-ray. So sometimes there are things that we could see on CT scan that is not necessarily seen on the X-ray. So in a patient either treated or untreated tuberculosis, if the tuberculosis has gone too far, if the infection is extensive, it could heal, but it could heal with a bad sequela. You could have fibrosis, and bronchial thickening. We call that bronchiectasis. We could have significant volume loss. Notice that the right lung has changes of chronic TB. This is the left side, which is maybe normal, but the right side, we have significant volume loss. We could even have a totally destroyed lung, if the patient was not treated immediately. So destroyed lung is something that is sad, but we see from time to time on patients who are not necessarily treated early for this particular disease. So primary TB infection could go into latency if the patient initially has good immune response, or it could proceed to primary progressive TB disease in a form of lung disease, lymph node disease, or disseminated disease. But later on in life, a TB infection could reactivate. It could go to the lung apices, extrapulmonary sites, and again, it could also be disseminated. However, there are complexities in the diagnosis of TB. Uh, Sometimes the patient is not responding to treatment, and sometimes there's a dilemma. You don't know if this is TB or not. No, the clinical manifestations and the radiologic manifestations do not align. So we could be dealing with drug-resistant TB, or it could be a TB-HIV co-infection, or it may not even be TB. It could be viral, bacterial, or fungal infection. Are we dealing with neoplastic condition or even foreign body aspiration, which could all mimic the clinical manifestation of tuberculosis? No? So this is a 15-year-old boy diagnosed with tuberculosis. However, the patient is not getting any better with TB treatment. Notice that the disease is significant bilaterally. We have multiple opacities, areas of cavitary formation. CT scan was done on this patient, and it does show multiple cysts with very thick wall, suggesting chronicity. And there are areas of bronchiectasis, and there are areas of fibrosis and multiple nodules. When you see this and the patient is not getting better in TB treatment, we have to think of drug-resistant TB. It could be resistant to only one drug. It could be resistant to multiple drugs. It doesn't matter. This is hard to see on X-ray, but your suspicion should be very high if the patient is not getting any better. No? So again, the imaging features could be multiple lung opacities and nodules. There could be cavities, bronchial dilatation, and fibrosis, and could even have pleural involvement. Keep in mind that, again, it's very difficult to differentiate a single drug resistance to multiple drug resistance. And these findings could also be seen in drug-sensitive TB. No? So we have to correlate it clinically. The first thing that you have to keep in mind is if the patient is not responding to TB treatment and the patient has previous TB treatment, but it could be, you know, incomplete, or the patient could be non-compliant. This is a 4-year-old with TB and HIV co-infection, and the patient underwent antiretroviral therapy and also TB treatment 3 weeks prior to this X-ray. Notice that there's significant abnormality in the lungs on both sides, and on CT scan, we see significant lymphadenopathy and lung disease. So despite the fact that the patient is being treated for HIV and also for TB, the patient got even worse. And then you have to think about TB iris, tuberculosis, immune reconstitution, inflammatory syndrome. Okay? So in this particular situation, there's a clinical deterioration weeks or even months after antiretroviral therapy. Okay? What happens is there's excessive inflammatory response to a pre-existing and probably partially treated TB condition. Or sometimes a patient is asymptomatic for TB and occult or unrecognized, but it comes out following antiretroviral therapy. This is a potentially life-threatening condition that needs to be addressed. It's difficult to distinguish TB iris from drug-resistant TB because both of them do not necessarily on imaging get better with the TB treatment. No, so on imaging, instead of getting better, the finding in the lungs and the lymph nodes gets even worse. This is a 13-year-old female with forearm sarcoma, proven cancer on the right forearm. Notice in the asterisk, we have significant enlargement of the lymph nodes in the right axillary area. But what is even more interesting, the patient develops multiple lymph nodes in the mediastinal region, and it is effacing the airway, the bronchus intermedius. So notice that with this finding, the patient would have difficulty breathing, and the patient would probably have a wheeze, and it could present and mimic like tuberculosis. But in this particular condition, this is metastatic disease. So mediastinal lymphadenopathy from cancer does happen, usually from lungs, neuroblastoma, Wilms tumor, or sarcomas. No? What we see on imaging is lymph nodes, large lobulated lymph nodes. You could be seeing single nodules, but more often than not, they are multiple and found in the middle mediastinum. They could necrose and they could even calcify. So this is another patient initially diagnosed with tuberculosis. Notice in the asterisk that there's collapse of the right middle lobe, okay, and right lower lobe. But what is interesting, there is a foreign body stuck in the bronchus intermedius, and this is an earring. Another patient being treated for TB until we did an X-ray, and there is a foreign body stuck in the bronchus intermedius, and it chronically collapsed the right middle lobe and right lower lobe. This turned out to be an eraser holder in a pencil that got aspirated. No? And this is another patient with foreign bodies stuck in the right bronchus. These foreign bodies could mimic tuberculosis presentation. So, however, this particular condition could present acutely, or it could be missed, and the presentation could be chronic. So, foreign body can also mimic TB presentation. So, in conclusion, tuberculosis is a global health concern. Childhood TB diagnosis and management can be challenging, and medical imaging from X-ray, ultrasound, and CT could play a very important role. It is important to be familiar with the imaging findings as I described. It could be in the lung, in the lymph nodes, or it could be disseminated. Keep in mind that if the patient is non-responding to TB treatment, further investigation is necessary because it could be a co-infection with other organism. It could be a non-infectious process such as neoplasm, or it could even be foreign body. And therefore, clinical radiologic approach is needed for more accurate interpretation. So, I've written a lot about tuberculosis in children. In April of 2023, we have released imaging recommendations and algorithms for pediatric TB. This is readily free downloadable online access. So you could get this particular journal, and it could explain to you further the things that I've expressed today. So with that, I'd like to thank you all for participating, and I would entertain questions if there are any.
Hello, Professor Lai. Thank you so much. This was a wonderful, really wonderful presentation, and we really appreciate, your time and just being able to share all these, I guess, images and your knowledge with us. We're so grateful for you. And yeah, I just wanted to say that on behalf of everyone, and we'll open it up for questions. If anybody has questions, please feel free to unmute or feel free to write your question in the chat, and then I could read it out loud. We could also.
And while I'm Don Fresh. I'm one of the organizers of the course. And Dr. Lai, thank you again. I've heard this before, but it continues to grow and be an excellent talk that is just so globally relevant. And for the